Thank you, Grace. I'm going to invite the panel to come have a seat up here and open the floor to questions for our panel. Just a reminder, the session is being taped, so when you step up to the mic, if you can introduce yourself so we can record, the sessions are being recorded. And as our speakers questions come up to the mic, we'll start off with some questions. Thank you to the speakers for your presentation, all very interesting insights into our technology and the challenges that exist in terms of bringing dosimetric superiority to the level of evidence sufficient for justifying the clinical utility. One of the themes that I think is common among the various technologies is this advance in the infrastructure. It's related to the development of the computing technology, that it is more complex to deliver, it is more complex to ensure accurate delivery, and to look at the issue of quality. And there is literature on the quality of the delivery of these advanced technologies affecting the outcomes. So wondered if the panel might comment on the additional impact of quality and how that plays into comparative effectiveness data.
Well, increasing complexity means increasing surveillance. Otherwise, there will be catastrophes. Through the first decade of this century, there was a phenomenal proliferation of new technologies in radiation oncology. And the proliferation was almost faster than our abilities as humans and as departments and physicists to keep up with them. It led to radiation oncology, being featured as a specialty in the New York Times in 2010. But as a result of that, we've become increasingly aware of the need to slightly damp down the growth of the adoption of new technologies. And the specialty in particular, now our specialty society, ASTRO, has led a move to sort of ensuring minimum levels of staffing and oversight. Everything requires a great deal more QA than we ever thought previously. Protons, of course, being at the highest level of complexity, need the highest level of QA.
I'll push the talk. Yeah, and then I would actually even like to add to that in terms of what we know from trials that have been done in the past, if it's from the RTOG trials, like using actually fairly routine radiation therapy to ask a question in, say, a pancreatic cancer. Does the addition of like a gemcitabine improve outcome? We know because back then we had the ability and the money to actually collect that data. We are able to easily show that in the patients who were treated appropriately, that there is a benefit of the drug, and in the patients who were like not treated appropriately, the drug failed. So the overall result of the trial is one of a negative trial. However, it keeps going back to this question that I think needs to be asked. If we design trials, should we be asking, is the technology today robust enough to be used and not have good quality in these trials? Or should we have really strict controls on quality to find out if these drugs or new technologies can one day, if used potentially more easily, affect outcome?
Take the first trial over here.
Ralph Weixelbaum, University of Chicago. I have a couple questions. One is for Dr. Zeitman. I agree with you on the pediatrics. I mean, that seems to be straightforward. Under what circumstances would you try to do a randomized trial with protons? And let me give you two examples. One is lung cancer, where 70 gray is worse than 60 gray. Now, I could see a phase 2 to try to combine dose-escalated protons with drugs. But in the current state, it's very hard to envision how it's going to help, because no one with locally advanced lung cancer is going to live long enough to reap the benefits if it is 70 gray really is not better than 60 gray. The second is prostate cancer, where it's very difficult to show a benefit of treatment in a certain age group. So am I thinking about this in the wrong way? And how would you, and I've one more question.
Well, I think about randomized trials in adults differently. I sort of divide the clinical categories into three groups. There are groups where protons are just pretty clearly superior, eye tumors and the rest. No need for randomized. And then there are indications where they can't possibly be superior. Skin tumors. I mean, no trials there. And then there's the gray zone. And the gray zones tend to include the common cancers. And I mean, it's worth doing a randomized trial because there may be advantages that may be small. Or we need to generate the data in order to drive the policy. We don't have to make policy ourselves. We have to generate, our obligation is to generate the data. So for the common situations like, prostate cancer anomalously was adopted by proton beam as the economic engine for the last decade. Now that is actually falling away because of active surveillance, because of robotic prostatectomies and other reasons. But for breast cancer and for lung cancer, maybe earlier lung cancers, one could make a case for phase 3 trials, either looking at dose or simply fixing the dose and looking at morbidity.
And the other question I had was for Dr. Shimura. In terms of the pancreas trial is a good example. That was fairly simple technology, as I recall, 3D CRT.
Right.
So given, it's not that long ago that it was done, right? Less than 10
Right.
years ago, given the same people are in practice, and those people were, it was a clinical trial, so presumably they had to submit their QA. Do you think that the specialty's up to this level of technology, even if it works?
I'm sure there's a lot of people who will get angry with me if I answer honestly. I think that what I will say is that prior to the combining of the cooperative groups and the huge cuts in the budget to QA, we do have some SPRT trials that actually we can look at. And I think it was when all of us actually looked at how patients were being treated with stereotactic body radiation therapy, seeing how kind of poorly it was done, kind of like drove us to design these new trials quite differently, knowing that we would never be able to really know if they hit the target, but we could at least help guide them, almost like the sign that says, please don't spill hot coffee. These current trials are designed to really do just that. And I don't think it is quite good enough, but at least it is better than like just assuming like that everybody has an army of physicists and actually read and think.
Next question.
Vic Vikram from the National Cancer Institute. Some of you who know me may know, remember that I used to have a full head of hair before I started getting randomized trials of protons done. So all of you pointed out challenges to doing randomized trials to generate level 1 evidence for the common cancers. And I would submit that it's not any different to drug development. Drug development also is very capital intensive, and there's always a newer and better drug potentially in the pipeline. So the fundamental difference, it seems to me, is that in the case of drugs, the FDA and insurers demand level 1 evidence, and in the case of devices that we are talking about, they don't. So I would like to hear your comment on that. A corollary is that in the era of precision medicine, as Anthony so eloquently pointed out, I mean, we're not talking about disruptive technology. These are incremental dosimetry benefits, okay, which may be valuable and clinically relevant. But one of the benefits of a randomized trial is it allows you to do a subset analysis to find out, okay, these are the 10% who really obtained the most benefit from this more expensive drug or technology, and these are 90% who did not. So I would like to hear your opinion about, can we do that from retrospective analysis? My impression is that really randomized trials are the best way to generate that kind of precision data.
So I think you raise a very good point in terms of linking this to the idea of drug development. One difference in particular for the radiation oncology side of things is in a prospective study for radiation oncology, one of the important outcomes that I talked about in terms of toxicity is something that we very much care about, not only in kind of the near term, not only in 1 to 5 year intervals, but even 10 to 20 year long toxicities for patients who are expected with a long life expectancy. And that can be a very difficult outcome to attain. But really, as mentioned, the therapeutic ratio is completely dependent not only on the cancer control outcome, but these toxicity outcomes. And to glean that important piece of data to truly define the therapeutic ratio, I think that is a key challenge for prospective randomized studies in radiation. As for your second question about the dosimetry challenges and whether the best way to obtain this evidence is through the randomized perspective view. Certainly that's one possibility. I'd also want to put forward this idea of using a registry type of approach to really be able to obtain automatically, if you had an interconnected platform, this kind of detailed level of dosimetry data that would really provide a level of nuance that has been previously not captured in any other kind of study design.
Thank you. I'd say another challenge with that is interoperability in terms of our vendor-controlled systems, in terms of comparing data. We talk about large data sets that link to each other and lots of data there. But in terms of policy issues, the issue of interoperability of these systems raises additional challenges when your EMR doesn't talk to your planning system, does not facilitate, and that is also a huge barrier to gaining, to reaping this huge data pool that's out there. Thank you.
Good morning. My name is Ron Klein. I'm a pediatric hematologist, oncologist by training, but a medical officer at the Center for Medicare and Medicaid Innovation. When Dr. Shea started the session, she talked about value. And as you know, value is benefit over cost. And I heard a lot of mentions of benefit and very peripheral references to cost. So I think that's something just in terms of the conversation, we need to talk about cost. The last time I checked, and perhaps I'm wrong, proton beam therapy was 5 times the cost of conventional therapy. Dr. Zeitman, I was struck by your slide about the UK adopting proton beam therapy as an endorsement of proton beam therapy, because at 1 per 30 million people, the United States should have 11 proton centers. I think if I remember the slide correctly, we have 42 with 20 more in the planning stages. So I would say the UK has probably come to a different conclusion. And I was also struck by the fact that with prostate cancer, with proton beam therapy for prostate cancer, after a decade of use and thousands of patients, the field is still struggling to define a benefit. So I guess I would say in terms of value, at 5 times the cost with difficulty improving a benefit 10 years out, I'd say that it's sort of a hard argument to, for proton beam therapy for prostate cancer. But as a pediatrician, pediatric oncologist, I agree for pediatric tumors.
Well, I don't disagree with you on many of those things. The British have done a needs assessment and determined that one facility per 30 million is about right. We don't do it that way in the United States. It's market-based, so we have a boom, we have a bust, and then we settle out at appropriate use, which may end up just where the British plan to be. The expense of proton beam is coming down. It's still about 2.8 times photons. It's coming down. There are big sort of efforts towards miniaturization. And I'm hoping that can be driven down further. I don't know whether that's realistic. And the proton question, the prostate question is answering itself because the prostate patients are disappearing.
Thank you.
Next question.
Yes, my name is John Gardenier. My background is in various forms of applied mathematics to practical problems, including statistics, econometrics, operations research. Related to that, I found that much of any analysis of that type is highly dependent on data system design and data quality control. And there are factors in mathematically based decisions that typically take into account subjective factors. For example, I did not hear in the analysis of benefits of alternative therapies for prostate cancers the preferences of the patients for positive elimination of the prostate problem versus risk of other damages. And yet there are great differences in the patient preferences for those, which probably should be taken into account. With regard to the costs over time, initial costs amortize and they eventually go away, depending how rapidly, depending on who's funding it and what they are interested in. But the operation and maintenance costs will continue, and they, unlike the amortization costs, have a tendency to rise over time. And making a distinction between those types of factors, and while taking into account that future first costs may be declining, but almost certainly future operation maintenance costs will continue to increase. But then finally, my other concern is with data quality. My wife and I are enrolled in a very prestigious healthcare system that recently introduced electronic records. In those high-tech electronic record systems, I have been assigned chronic conditions that were my wife's. My wife has been assigned chronic conditions that were in my record. So there was a terrific quality control problem, and in my experience, this is universal across data system design. So my question really is, are the skills of people who are specifically trained in life cycle cost analysis, in data system design, in quality assurance for data systems, as well as the mathematics, are people like that involved in the design of the analyses that you're talking about?
I think the short answer to that is probably not enough. And I think you bring up several very important points. In terms of the patient preference variable, I think it's extremely important. Another component of that is the patient-oriented or patient-centered view of even costs, that there's not only cost to the payer or cost to society, but overlooked costs for patients themselves, not only out-of-pocket costs, but productivity costs. For example, what is meaningful to the patient to come in 10 times or 15 times for treatment versus 1 to 3 times? How is that meaningful for one patient versus another patient? So I don't think that we have necessarily, as you said, a systemic way of being able to collect these data and understand how to feed that into the equation for value. I think that's a very good point. And secondly, in terms of the quality assurance for some kind of centralized system, I completely agree with you. It's not as simple as finding an infrastructure to say that the data can talk to one another, and we can, if we just had a magic wand to be able to connect everybody's electronic medical databases and then the treatment delivery database that we have in radiation oncology, that would solve the problem, but that there's so much data out there and the potential for errors, such as you mentioned, that it's really a huge undertaking. So from a design perspective, that's a great point.
Next question.
Jim Moeller from Roswell Park. Years ago, if we were having this meeting, we would be talking about neutrons versus photons. And I just wondered, when I remember right from high school physics, a proton and a neutron are the exact same molecular weight. Neutron beam therapy has gone away. I think it's disappeared. And why did that happen? And is there something to be learned if we compare neutron beam to proton beam therapy, since they develop kind of along the same timeline, and one's gone and one is here and building all these new centers?
It's a great point. Neutrons are also generated in cyclotrons, but that neutrons, protons have a different physics from regular radiation. Have a different physics and said to be a sharper knife. The thing about neutrons was they had a different biology. It was not a different fit. They want a more accurate treatment, but they were supposed to have more biological oomph against the cancer. It turned out they had more biological oomph against normal tissues as well. And neutrons fell by the wayside simply because the morbidity was unacceptable.
And why is that if they're the same size, same mass, and same delivery system?
Oh, I don't know enough about the details of the biology. Ralph will give you a primer afterwards.
The neutrons, especially in the brain, have a higher activation cross-section, there's a higher absorption by hydrogen, so they cause substantial brain necrosis,
Yeah.
As well as other kinds of problems. Plus, they had no depth dose delivery advantage like protons do. Also, many of the machines and delivery were fairly rudimentary at the time. Unfortunately, we published a number of papers with severe complications from neutrons.
And so Neutron went away without the benefit of any level 1 evidence.
Well, actually, there was, I think, one trial on salivary gland tumors, and I still think that it is approved for salivary gland tumors. So I think here we just want to be careful not to throw the baby out with the bathwater, that there are probably very interesting things to study. I think some of this is because of the, as Tony's pointed out, the proliferation of investor-driven centers. And once you invest $250 million, you're not going to do a trial that shows it doesn't work. It's just not going to happen.
Next question over here.
Hi, I'm Jason Evstathy from radiation oncologist from Massachusetts General Hospital. One comment, one question. The comment is just what Grace sort of pointed out. I think credit to our field and to our professional organization, ASTRO, and the Radiation Oncology Institute for being a relatively early embracer of population-based prospective registries and completing a pilot in prostate cancer aimed at assessing quality delivery of radiation in the U.S. And so I think that it highlights that our field has been committed to sort of evidence collection and generation. The question is to Anthony, as a residency program director, it has always struck me that our field is actually uniquely based in evidence in its training. We have a lot of randomized trials that inform practice in most disease sites and definitely in all the common disease sites. I just was wondering if you could comment on kind of the culture of training of our professionals in our field and how our field seems, I mean, obviously not uniquely, but very based in evidence in its training.
Well, that's a very sort of interesting perspective to bring up here. But you're absolutely right. I mean, we're a small specialty. We're the sort of Cinderella in the multidisciplinary clinic. There are the surgeons who are there rightfully, and no evidence required. That they are the colossus of multidisciplinary clinic. There are the thoughtful medical oncologists, and there's radiation oncology. And we're a small specialty, so we've always had to justify our place. Ever since the early days of the field, the very first residency program, Del Regato's program in Colorado Springs, emphasized developing evidence because you had to justify your existence at the table. So I will say everything we've done up to this point in radiation oncology has been evidence-driven, a very evidence-driven specialty. The proton piece is actually anomalous and something that we're sort of seeking to right.
And yet, we're embracing even that question with a number of phase 3 randomized trials and other efforts.
Yeah. I mean, the ramp-up of protons has been so slow, it goes back sort of 60 years. And there are only 2 centers until 2004. And it's only recently that there's been a big takeoff of centers and the real possibility to do these kind of trials. Now we can. Now we will.
And I'd say another thing that I think we're going to talk about a little later in this workshop is the ability to collect this evidence as it's aided by the possibility of coverage with evidence development, to put the responsibility on gaining the data in these technologies instead of just clinically employing it without being able to study the outcomes. Next question.
I'm Turkan Gardner from Pragmatica. As a statistician, as I have worked with randomized trials, some of the terminology that have been used are single blind, double blind, placebo effect, matching. And I'm not saying this in terms of comparative effectiveness, but statisticians try to use a baseline, a placebo effect of where you're starting from before making comparisons. And in surgery, it's very hard to have double-blind studies because you know what is being applied, and it's very hard to do matching among patients. So one of the things that we should consider, since this is a workshop, is under what context can we use a complete randomization from a baseline? And I admire very much the charts that have been produced, but it's one type of therapy against another. And you cannot have a placebo effect by not treating patients. So these are realities that we should consider in designing trials as well as evaluating them. Thank you.
There have been some sham radiotherapy trials, I think, in orbital graves. We've had some of those, but I agree they're very few and far between.
And also in Britain, when I was a resident, I remember a trial of dermatitis of the hands, a benign condition that was being treated with radiation, but the radiation was only given to one hand. The machine wasn't turned on when the other hand was treated, but the patient didn't know.
So Ted Lawrence, University of Michigan. Actually, when I was a resident at Stanford, there was a placebo-controlled trial for ankylosing spondylitis and whether radiation had any benefit on that. But that wasn't my question. So I think that our field, I want to return to a prior theme. Our field has a pretty good track record, not perfect, but a pretty good track record of trying to seek out data. And I think I was involved in the 80s and early 90s in the so-called 3D hypothesis that Alan Lichter had proposed at Michigan, in which you used a better technology, 3D over 2D, to first decide if you could either escalate dose beyond what you could do with 2D, and then the second phase was to see if that increased dose could improve outcome. And I think as a field, we did that reasonably well. And even with IMRT, maybe we weren't quite as good with IMRT, but again, using the new technology to either spare normal tissue in a setting where control was already good, or increasing dose where control wasn't good. But now I think in the proton era, we've hit a new problem, and it's le piège. It's when you have, because both with IMRT and 3D, certainly there were investments in the technology. There was some money involved, and there was intensity of therapy involved, but nothing like the investment in resources that was required for proton therapy. So to me, that the heart of what has happened this morning is really codifying le piège, that the fact that you've invested so much in the proton therapy, it's difficult for an institution to run a trial that might suggest that proton therapy isn't beneficial. So how do we get out of le piège? That's, Anthony, I guess that's your question, but really it could be the question for all three speakers.
Well, I think it's the question for the whole workshop. I mean, if we could come coverage with evidence development, encouraging the use of trials in multiple clinical situations. I think there's little doubt that protons are going to be advantageous in some situations and not in others. It may be that the number of proton centers that we have in the United States actually is unsustainable when the evidence finally comes in. And if we've overshot and we roll back, so be it. And there's consolidation, so be it. And we may have to accept that.
Because I'm struck too that I think there are something like close to 10 companies, right, making protons right now. And you look at linear accelerators, which is a much bigger market, a very well-established market. There are essentially 2 companies. So this is telling us something, isn't it?
Vic Vikram, NCI. So we've been beating up on protons, and I would like to give Anthony a break and turn to IMRT. Maybe the train has already left the station, but one of the slides that was showed the increase in radiation oncology expenditures to Medicare, and that has largely been as a result of the adoption of IMRT over the last 15 years. And I don't want to leave the audience with the impression that there's no downside to IMRT. as Steve showed the slide of the British trial in head and neck cancer, which showed very clearly that you reduce xerostomia by using IMRT as opposed to 3D CRT. What he did not show, and is never shown in meetings like this, is the other slide, which shows that over the long term, the patients who had IMRT had worse tumor control. So there is a potential downside. To put it crudely, it's very easy to decrease toxicity. Don't turn the damn machine on. So the question is not whether IMRT or protons can reduce toxicity. The question is, can they reduce toxicity without compromising tumor control? And I would submit that the second part of the question simply hasn't been addressed in any meaningful fashion. So there is a possibility that this technology, which is widely used in the community now, that patients and Medicare are paying more, but in fact, they may be having worse tumor control. And I think as a community, hopefully the registry will address issues like that. But it is not a trivial issue because there is a potential downside to decreasing toxicity. We learned that from erythropoietin. And maybe some aspects of IMRT need to be looked at from that perspective.
So I think, like, just to add to that, I think that just underscores why we need this robust quality assurance on these trials. It goes back to the idea that currently, even if we do have the few dollars to collect some quality, it's only in terms of the plan. So it is only time zero. It says nothing in these complicated patients and like delivery if in fact every day we are in fact hitting at target. So it's very hard to say that IMRT may lead to worse control. It's probably easier to say, well, that the volumes have been poorly defined. It's still quite unclear in like breast cancer as a perfect example, even what volume should be your superclap dose. So as these knives become sharper, as we can fall dose off more quickly, if we don't even know our target and we can't even prove at people doing and hit it every day, it is surprising that you don't see worse tumor control more often.
I would agree with you, except to qualify that it's not quality assurance in the trial that is important. It's when the technology is disseminated in the community, nobody has the responsibility for ensuring that quality assurance. At least for NCI-funded trials, the NCI mandates that you have to at least radiate a phantom to show that you can radiate a piece of plastic accurately. In the community, in most states, the only requirement for treating with IMRT is that you don't be a recently convicted axe-murderer.
And that gets back to that question of quality and regulation and the policy issues of requiring training and licensing of folks like allied medical professionals like physicists.
Patty Gans, UCLA. So I am a member of the National Cancer Policy Forum, and I've sat through a lot of workshops. In fact, we just had one a few months ago on mammography quality. And so, this is true of almost every technology. I'm also a member of, I'm a breast medical oncologist. I'm a member of the newly consolidated group NRG. I've worked with the surgeons now for a long time and now are appreciating what goes on in radiation oncology. And there is a tremendous amount of training. When we did our sentinel node biopsy trials in breast cancer, there were surgeons who actually went to the OR, proctored, surgeons in doing 10 surgical cases to do it right. Yet that had disseminated already in the community before they did that trial. Same thing as I know for radiation oncology. And the same thing was true in the mammography reading. If we look at, cervical cytology, all sorts of things. So this is a generic problem. I don't know if it's true in other countries where they have different health systems, but delivering on what is the evidence once it gets into the community is really a problem. And I see this not only because of the high cost of this, but the harms that obviously can occur if it's not delivered properly. So that's kind of the preface to the generic problem, because when you have the hammer and you've shown the hammer works, is it actually being used properly when it's delivered? The second thing is, when you have that hammer, you're going to use it for everything. We have robots that are being used for surgical procedures where it's absolutely not necessary. I went for a mammogram a couple of months ago. I'm not at high risk for breast cancer. I got a 3D tomographic mammogram, which I wasn't asked if I wanted it, but that's what my institution installed. And that's what I got. I'm sure it was much more costly to the health insurance system. So that when you have a new technology and you buy those machines and you use it, you know, IMRT is used for all sorts of treatments where it may not necessarily be superior to photons. And we're going to have the same problem with protons. How do we, other than having an insurance system that says we're not going to pay for it, you know, how do we, in fact, prevent the creep of we've got the machine, we're going to use it. We're not only going to use it in a situation where it's not appropriate, someone's not going to survive a long time to get those benefits, but we're going to use it where there's no evidence.
Well, I think you've really spoken to the thematic heart of the Choosing Wisely campaign. And specialty societies have been asked, as everyone knows, to come up with 5, 10 things that their specialties are doing that are costly, that add remarkably little value, and served sort of to drain the public purse without improving patient outcomes. And most specialty societies have enthusiastically embraced this concept. Now, granted, it's a somewhat toothless concept because it's not enforced. But it's a huge step in the right direction. So Astro, and it's among its first 5 Choosing Wisely recommendations, one of them was, you know, stop and think before offering protons to a man with prostate cancer. This man should be in a clinical trial if he's treated at all. So I think the specialty societies can at least push the physicians in an ethical direction.
Just one other comment. You're lucky you didn't get an operation, Patty. That I think the elephant in the room is and I think this is true for a lot of specialties, is the organization of tertiary care or quaternary care services in the United States. So there's abundant evidence from a lot of specialties that the more you do, the better you get at it, mostly. Certainly for coronary artery bypass, this is true. And I think that, you know, I'm fond of saying in Toronto, there's 60 linear accelerators in 2 places. In Chicago, there's 60 in 60 places. So I think that if there were better organization of high technology, we would have more experienced physicians doing it. There'd probably be less incentive to do unnecessary things, and it certainly would be less expensive. Whether it ought to go to the extreme of Britain, I don't know, but I think that certainly, and it doesn't necessarily have to be in an academic center, it could be in a large practice, but it ought to be large enough to do the kinds of QA and have the resources that are required to at least study these things.
Hi, Ann Geiger from the NCI Healthcare Delivery Research Program. I wanted to follow up on something Patty said. Choosing wisely is wonderful, but it's about stopping things. And if you know anything about behavioral economics, taking things away, even if people don't benefit from them, is very difficult for people to accept because it feels like a loss. And so I think Patty's question included a piece that Choosing Wisely doesn't address, which is how do we keep people from getting something they don't need or doesn't advantage them so that in 10 years we're not now trying to take something away and people are saying, why aren't you giving me my care? So I just want to caution us about choosing wisely and focus on the harder question, I think, which is how do we keep institutions from, oh, we've got the machine and we don't want the room empty, let's get somebody in there to use the machine. So that's just a comment rather than a question.
Hi, I'm Mike Steinberg from UCLA. You know, a number of policy questions have been raised here. The generalizability of this technology into the community. But the question I want to raise is funding. A comment earlier was made that devices are like drugs in terms of need of randomized trials. However, the drug delivery platform allows for the money to do those trials. Device companies are a fraction of the size of the drug companies. How do we get the funding to do the needed trials?
And for me, that is, first of all, you have to decide what is a medical device. You know, because there are a zillion medical devices. An iPhone used for a physics calculation is a medical device, but we're not going to do a randomized trial with that. So the first thing you have to do is define what devices are so really need evaluation. And then there's going to have to be some collective, but there isn't much vendor incentive at the moment to finance these studies, obviously. I would like to turn to them, but we can't. It's going to have to come through some combination of restriction of who can use the new technology and a tie-in between new technology use and evidence development and payment. Now, that's the only way around it I can see.
Take one last question, then I think we need to.
Jay Hoy, I'm a manufacturer from Electa, one of the two. Couple of comments and a question. First, and I think this is actually playing off of what Michael just said, I think your comment. There's a fundamental difference in the financial structures of drug companies and device companies, which ties right into our reimbursement system. In a nutshell, drug companies spend a significant amount of money on R&D. When you look at the cost of goods sold for those drugs, they're enormous compared to a device company, which spends a lot on R&D, but also has a very high cost of goods sold when you build these machines. And the margin a device company makes on a device versus a drug company is not even comparison. Now, someone, I think Tina said, she put up a little graph up there. There are patents in the device industry, not as many, but they are there and they're protected. But it does point to radiation where many of the patents have long ago since run out. But the new technology that you see, multi-leaf collimators, IGRT, et cetera, there are patents on those. Now, given the structure, we've been talking about randomized trials, prospective and retrospective trials. You mentioned bringing in the SEER data with the Medicare data. Those are not quality control like a trial. On the other hand, you do have registrars and billers that are coding that information. Going forward, where do you see the role of trying to do better quality or better implementations of systems to gather that retrospective data that's much needed, I think, because I think someone talked about a very controlled randomized clinical trial versus the real world when this technology gets out into the community hospitals where you see what's really going on. Where do you see that going and what can we do to affect that future? Randomized versus a retrospective versus prospective trials.
I think we could probably learn from the non-radiation oncology or the non-oncology world. So one idea is to look at kind of the open access data effort just in the general clinical trial world, where there are participants who are willing to basically volunteer their data into a centralized format to understand that there will be secondary users of that data when their primary question is being answered, to understand that there's so many questions that can be asked and answered, but potentially not, enough resources to be able to actually work on those questions. To structure that data in a way that protects the privacy of the patients, and then understand that there has to be a quality component to the design of the studies, so that there has to be some kind of, I don't want to say governing body, but body that tries to, promote good science, and then to understand that, only in the power of the collective data as we kind of collect it prospectively can we answer some of these questions in the cleanest way possible. Because when we look backwards at these registry type data, even with the best kind of statistical methods, I just don't think we can really come to the clean answers that we need to be really moving forward. I mean, I think we need all of them in partnership, but that's really not our only answer. And I feel that, looking to the non-oncology world, there are already some models developing, and we can use some of those models.
I would just like to add in response to Michael's question, the taxpayer dollars to conduct these trials have been available. The problem has been motivation of providers to participate because neither the FDA nor the insurers nor the states have demanded these trials in the past.
Well, in the interest of time, we'll finish up. I suspect many of these themes that overarch will continue to be discussed as we move through this workshop. But thank you very much, everyone, for your time and attention, and thank you to the panel.